All right, ladies and gentlemen, thank you. Thank you so much for joining us. We are transitioning into a legislative panel. These discussions are very common in the legislature, so the format is slightly different than what we did with the good doctor, who I know is going to be here for a little bit, and we may loop him back in here or there, but we appreciate the doctor staying for a bit. So what you're going to see is you're going to have legislators come in and come out, typically during the program. Again, this is the mental health legislative panel. The disability legislative panel will be up at 2 o'clock. Okay, so what we have is we have a set of speakers who are going to run through some topics. The legislators will ask questions. These policy hearings and panel hearings are very important to the legislatures because for so many of us, this is like the main way, God bless, this is like the main way that we learn. One of the main ways that we learn is by doing these types of discussions. So they're very important to us, okay? So we have two different panels, as we mentioned here, but two also in this. The first panel is going to be regarding the recommendations of the Behavioral Health Commission for adult mental health, which the good doctor, I think, made reference to earlier. We're going to start there. And then our second panel will be on mental health needs in schools. So that's what we have for this topic. So we're going to work our way through. So, and listen, on these things, because I know my staff, we kind of collected a bunch of questions. Questions do become at times difficult for us to integrate in. But I want to let you know, too, that no matter what panel you're in or what program you're watching here today, don't leave if you have a question. Write it down, put your email on the card, and I guarantee you we will find answers for you, okay? So just so you know, that's what we're going to do. We're not going to ignore anything the best that we possibly can. So just write the questions down in any part of this and leave it with my staff. And even if we don't talk about it today, we will make sure you get an answer. Okay? Everybody, please make it difficult for the interpreters. Okay? All right? But yes. So, and I will introduce and we'll hopefully help with that as well. Okay, thank you. So before I start, before we get into our panelists here, I want to be sure to introduce the legislators who are with us now. Again, you'll see people kind of ebb and flow over the time, but we are very excited to have this group here. The microphones all work, guys. That's fantastic. All right, so first I'm going to let them introduce who they are, where they're from, and I know we have a couple chairmen here as well. So all the way to my left.
Good morning. Thank you for having us here today, Dan. My name's Dan Deasy. I'm right down the street in District 27.
Jessica Benham, District 36. Grateful to be here.
Hi, good morning. I'm State Senator Jay Costa, Democratic leader, 43rd District, which is half the city of Pittsburgh, eastern wards, and also the eastern suburbs of Allegheny County. Great.
Arvind Venkat, 30th Legislative District in the North Hills of Pittsburgh, and I'm an emergency physician as well.
Good morning. I'm State Representative Sarah Innamorato. I represent the 21st District, which is the city of Pittsburgh and northern Allegheny County.
Good morning, everyone. My name is Mike Schlossberg. I'm state representative from the 132nd District in Lehigh County. Joe beats me for farthest distance traveled, but not by much, and I'm very involved in mental health related issues. I'll be speaking about some of our work shortly.
Thank you, Mike. I'm Joe Hohenstein. I represent the 177th District, which is almost in New Jersey. I represent the Philadelphia neighborhoods of the River Wards and Lower Northeast.
Good morning, everyone. Representative Latasha D. Mays, representing the 24th Legislative District. I represent the east end of Pittsburgh, from Oakland and University of Pittsburgh over to Homewood and East Hills. Great to be here today.
Representative Dan Frankel, 23rd District, east end of the city of Pittsburgh. I'm the Democratic chair of the Health Committee, majority chair of the Health Committee.
Majority chair, yes. Good morning, everyone. Apologize for my tardiness. Ariane Abney, State Representative, 19th District, parts of city of Pittsburgh, North Side, South Side, Hazelwood, Hill District, downtown, and parts of the West End as well. And I'm glad to be part of this conversation. Other than being an elected official, I am a social worker, so this conversation is something that is very important to me. Thank you.
Thank you, Ariane, and thank you, everyone. As you can see, my friends have come from near and far. We very much appreciate it. Some of them have fought their way through some crazy things to be here, so I appreciate that as well. All right, so we're going to start off first with our recommendation on Behavioral Health Commission for adult mental health, and we're going to kick it off for some summary from one of the key members of that commission. I'm going to turn it over to my friend Mike Schlossberg. Mike?
Thank you, Mr. Whip. And first, in all seriousness, let me say thank you. It is genuinely wonderful to be here. As someone from the eastern part of the state, let me start with the obvious. I hate your roads violently. Why? Grid patterns, people. Why? But more importantly,
called hills.
I've heard of these hills, but they're very inconvenient. But mental health. Sorry. All right. And from a mental health perspective, let me first state something obvious. You really usually don't get this broad of a turnout at hearings, and it speaks well not only to our regard for Representative Miller, for Whip Miller, excuse me, but for the importance of this issue. And you've got a lot of people here who are truly dedicated to making a difference, and we are hoping to make some real gains in the budget. And what is in front of you with the Behavioral Health Commission report, I think, can be a big part of that. I don't think I need to convince any of you of what a massive problem mental illness is. The only thing that I will say is we keep hearing, well, after COVID, things have got really, really bad, which is unquestionably true, but things weren't great before COVID. As we all know, COVID just made all the problems in our society that were already bad worse. In fact, and I was having this conversation with Rep. Miller and Hohenstein yesterday, in January 2020, I stood with Governor Wolf, former Governor Wolf, at a press conference, Your Voice Matters PA, and he was going to make 2020 the year of mental health, and then that thing happened and everything kind of went out the window. The good news from a COVID perspective is that it really did highlight some of our problems and help generate some political will necessary to tackle these issues. My role in mental health is multifaceted. I'm the co-chair and the co-founder of the House Mental Health Caucus, which is a bipartisan group of House members who care about mental health, who are extra engaged in it, and who try to inform themselves as much as possible about issues. We seek to pull together coalitions to do good work on mental health-related issues. I'm sure that many, if not all, the members who are sitting here are, in fact, members of that caucus. That caucus has been critical to building bipartisan support for mental health-related needs, support that is informed not only by our constituents, but frankly, by personal experience. I see a lot of familiar faces in this audience, and if you've heard me speak, you know I've been pretty upfront with my own struggles with depression, anxiety, and suicidal ideation. And I think it's important that we share our personal experiences because we need to destigmatize the issue. I think a big part of the reason mental health hasn't made the gains that physical health has is because there's still that stigma, and there's a self-stigma as well. So I try to always mention my issues so people know that if you suffer, you can still succeed. Part of that success turned into last year's budget. Now, the state, fortunately, is in a relatively strong financial position, and we were able, working with Republicans, who still had the majority in last year's budget, to take $100 million in federal funding and allocate it for one-time mental health needs. Now, to be clear, it wasn't exactly what I wanted. I came up with a plan for $100 million for recurring behavioral health needs. Unfortunately, we couldn't get there, but $100 million in one-time money is a decent amount. It is, to an extent, a drop in the bucket, but it makes how you use that funding critical. Working with a group of other legislators, advocates, stakeholders, and members of the Wolf administration, now members of the Shapiro administration, we came up with the Behavioral Health Commission report. Now, this report was designed based on input across the state and with input from a series of stakeholders and legislators for how we would spend, ideally, that $100 million. I'm not going to go insanely in-depth into it. What I will say is it called for about $38 million in workforce investment, $38 million in service expansion and integration, and $23 million for criminal justice-related issues. That report was adopted unanimously by the Commission, presented to the legislature, which will probably not enact the report as is, because that's never the way this goes. Some of the pushback that I've gotten on the report, and honestly, I think it's relatively fair, is that when you have a large commission, it tends to take a lot of money and spread it maybe a little bit too thinly. We took the report and introduced it. It is House Bill 849 in front of the Human Services Committee. We are trying to work in a bipartisan way. Democrats do have a 101 to 100 majority, so a majority of one, which basically means, guys, please be really careful when driving home today. That'd be great. Obviously, the Senate is still Republican-controlled, and we do have a Democratic governor. But what it means is we have to work in a bipartisan way. So right now, the bill is in the Human Services Committee. We are working with both Democrat and Republican committee chairmen to get a product that I hope we can agree to, if not unanimously, then pretty close, and then make sure that the final report is integrated as part of the budget. And the last thing I do want to talk about is the budget, because from a mental health perspective, it was a really, really good budget. This should, I genuinely believe, be enacted as part of the budget, but that's not all. Governor Shapiro continued with Governor Wolf's initiative to put $100 million to mental health in schools. He also is funding 988 in a sustainable way. I suspect most of you know what 988 is, but it's the suicide prevention number. 80 to 90% of the calls don't actually need any additional follow-up besides someone to talk to. Here's some numbers that you could call and help somebody get the help that they need. But 10 to 20% of those calls do need further involvement, either from mobile crisis centers or law enforcement. Governor Shapiro is taking the 911 fund, renewing it, but taking a piece of that fund and using it to fund 988 to create sustainable funding for mobile crisis care. It's a big one. We need to get it over the finish line. And finally, Governor Shapiro's budget calls for a $20 million restoration of the $67 million that was cut in former Governor Corbett's budget back in 2012-2013. That funding was cut from counties and has not been increased since. Forget inflation. Just, it hasn't been increased, which means that our counties who provide base services for people who need it the most have been cutting programs left and right. So this $20 million is a down payment towards full restoration. We're in a good position for mental health. You have passionate, deeply caring advocates here, and we want to make sure we not only do right by this issue, but spend our limited funds in the best way possible. I am happy to answer questions, but I've also talked a really long time, so Mr. Whip, I'll turn it back over to you, sir.
Thank you, Mike, for that great summation. And obviously your advocacy on this area is second to none, so thank you. I do want to note that we are joined by two other representatives. On my right here, I get stage left, right? Is that right? There's Representative Markozik. Brandon, thank you for joining us. And over here is Representative Tarek Khan. Appreciate it. Thank you, Representative Khan, for coming all the way from out east. Okay, there are two speakers as well that we have coming in next. I'm going to give a real, I always say when I do somebody's bio, I cut it down. They're really good people, okay? But I try to cut down. So first with us is Dr. Doreen Frederick. She began her career in behavioral health as a staff nurse at UPMC Western Psych and now serves as Vice President of Ambulatory and Community Behavioral Health Services at UPMC Western Behavioral Health and as a member of the PA Behavioral Health Commission for adult mental health. That's all she's ever done. Okay. With her is Christine Michaels, who is the Chief Executive Officer of NAMI Keystone PA, the state organization in Pennsylvania for the National Alliance on Mental Illness, obviously, the nation's largest grassroots mental health advocacy organization. Ms. Michaels has more than 35 years of experience in community health service delivery, social service agency administration, public policy, and legislative advocacy. So thank you both for allowing me to do such a poor job of your bio. But we will look forward to hearing your comments, and we'll start with Dr. Frederick. Thank you.
Great. Well, thank you, everyone, for the opportunity to come and speak to you today on this subject that Christine and I have partnered with, boy, like a lifetime, around advocacy and staffing. And as Representative Schlossberg said, this workforce issue isn't new to the pandemic. It's that the pandemic shined a light on all the areas of vulnerability that we have in our system. And it gave pause to our staff to really evaluate for themselves, what is it that I want to do with my career? And many people made a decision at that point that this is untenable for me. I cannot continue to work in this kind of environment. And we saw a large number of people leave the field in 2021. Moving to areas of private practice where people felt like they had more control over the work that they had. They were no longer burdened by regulatory and administrative workload, and they were able to choose the people that they would see. And now we're starting to see people return face-to-face and return back to the workforce, but we're seeing shifts in what those workers look like. We lost a lot of our therapy positions, and we're stable in our community-based services. Now we're seeing the reverse.
I'm sorry. We're going to have to kick you out. You got it? It's all good. Thank you so much. I'm sorry, Dr. Frederick. Go ahead.
That's okay. So, we've been experiencing this roller coaster of a staffing experience. Dr. Adair talked a little bit about telehealth, and that was very appealing, and many people thought that that was really where they wanted to be in their career. And now we're seeing more people who want that human connection, want to be back face to face. So that's kind of the tip of the iceberg. And it's not just in the therapy sectors that we're seeing staff crisis. We're seeing staff crisis in our community-based services, our mobile services, and our residential services. We have been advocating on the intellectual disability side for years around workforce and the workforce crisis, which is a whole other topic, but this, again, isn't new. I was working with a group of colleagues not too long ago to revise and revamp our white paper from the Conference of Allegheny Providers. The Conference of Allegheny Providers, as an aside, is a group of committed providers within our county advocating for the benefit of our the consumers in our area. So one of the big things that we've advocated for years is regulatory relief. So we were putting together our white paper, and I pulled out of my archives, if you will, information and paper from 2024 with the same regulations, the same language that we just dusted off and updated, that we have never been able to move the needle to create some relief for the workforce. Christine, you want to chime?
No, I just think you misspoke.
Oh.
2014,
2024, 2004, I'm sorry.
Yeah.
It was 2004.
There we go, 2004.
Yeah, I'm sorry, thank you.
Yeah.
Yes, yeah, so 2004, no movement. It's just been this circular conversation that we haven't been able to make any headway. So now here we are. In the pandemic, we had some regulatory relief, and guess what? We saw that no harm came to people as we experienced regulatory relief. As we unwind and walk back from the pandemic, it's a little bit of the same chaos that we had pre-pandemic of understanding what the new rules are going to be, how do they apply, what are the, in some cases, around telehealth, rules that are so onerous that make it very difficult for providers to serve people in a telehealth way. Just encounter verification form is a very specific example when an individual signs for the service that they received. So regulatory standards, a huge issue, a huge barrier for us, but not the only thing that's happening. I think I also want to speak to the fact that we have a lot of good things that are happening in terms of our workforce development. I'm not sure how familiar everybody is with what's happening in Allegheny County, but our Allegheny County leaders have developed what is called the Behavioral Health Fellows Program. So taking initiative to look at how can we use Medicaid funding to support workforce development. And in that spirit, how is it that we create pipelines to create pathways for individuals? How do we build in training? How do we build in support? And oh, by the way, after a 2-year commitment, how do we build in tuition reimbursement for people at the bachelor level and the master's level position? That program's kicked off, and so we're just starting it, and it's been a great partnership as everyone tries to work it through together and understand the benefits of that. So I think that's been an exciting change in our workforce. I think it's also important that we have to start to look at what does our current workforce look like, and how do we funnel people into care. Not everybody needs the highest level of acute care. How do we incorporate peers? How do we incorporate our paraprofessionals or individuals with bachelor's degrees who traditionally cannot bill in a fee-for-service model? So we have that happening. In this whole construct, we have to, I think, understand how we're reimbursing these services. How can we do a better job of being able to accommodate more people and fund these services in a way that isn't a productivity-based model or a fee-for-service model, but it is we can get you what you need kind of model. Chris?
Yeah. I have to follow that.
You do.
Okay.
Thank you, Christine.
Thank you. Thank you for having me here. Thank you for the turnout, too. I think I'm going to speak to the workforce shortage from the perspective of families and individuals who are seeking services and they're not there. Or the services are stopped and ended, and now they're stuck, okay? And I know that the provider community refers to themselves as the safety net, and I would propose that families are the safety net for children and adults who aren't able to get services, because that's where folks end up. The call goes to the family. If a residential program is short-staffed and has to close, where do those people go? They go home. We had a story last year at this panel of a mother who actually lost her house because she had to stop working and take care of her adult child. That's happening all over the place. And as far as waiting lists goes, there are a number of people who never make it on a waiting list, okay? So you have no way of capturing that number. We met at the end of summer last year, a woman from the hospital council. She worked in one of the senior care facilities, and we had presented, and she came up to us after and talked to us about her son, who she had been trying to get into services since January. This was like August, September, and she couldn't get him on a waiting list. So a lot of providers aren't keeping a waiting list, okay? Because if they don't keep one, then they don't have one, okay? So you can't capture that. And the only way she could get her son's services was if he became an emergency. So in January, a child could totally decompensate from January to the end of summer. I mean, it's horrible, and that's what's going on. I think the average wait time for children's just an outpatient appointment, an intake, is about 3 months, and I think that might be good. I know it's longer in some other areas of the state. So I think that's the side of the workforce shortage that maybe the legislators and the Behavioral Health Commission didn't get a full picture of, the families and the folks, how it impacts them. So.
Yeah, thank you so much, and thank you, Mike, for leading off the discussion with that. I do want to note that we are joined by my friend from up north in Allegheny County, Representative McCurry. Thank you so much for joining us as well. So we appreciate that. Okay, a lot of information there. We're going to do some questions and go to the next pickup. We're going to start off with Representative Hohenstein.
Thanks, Whip. I've got a question on workforce development, specifically within SUD services, and we were talking about peer, the increase in utilization of peers for services, and it strikes me that, and this is something that some folks in the field have suggested to me, and I'd like to know what you guys think about it, the idea of improving access to treatment and then building on that by allowing the folks who successfully complete treatment to then enter into the workforce, and then you're increasing services, and that just builds on itself. Are there any programs that are utilizing that type of model where they're really focusing on the concept of increased peer counselors as the beginning of both getting to the obstacles of entering into treatment and also the challenge of workforce development? I'd just like to hear your thoughts on that.
Sure. We use that model quite a bit in terms of workforce development. We have a lot of people who engage in treatment and then really want to give back and contribute in some way. And so we have been growing specifically our peer services, not just in the mental health side, but on the SUD side. So that is a model that we currently use. Now, the other really cool thing about this is that the peer role may not be the end pathway in somebody's career journey as a peer. We have one individual who recently received her MSW and will begin her licensing studies. So she will move from peer to therapist. In fact, she's moving to therapist next week in one of our outpatient settings. So she's going to bring a lot of amazing context to that particular role. So yes, we actually encourage that.
What kind of things can we do in the legislature that would help those programs move forward? Because, you know, the obstacles to employment are still there, and you know, even when people get the education.
So there's a number of things. I feel like, I believe that we have limited frequency of trainings that are offered within our state for peer certification. Also, peer certification is a very expensive training, and it's a 2-week intensive training. We need to provide provisions for individuals who are not associated with an organization to be able to pay for and have some sort of scholarship to participate in the peer training and examination. We also need to have pathways for community organizations who do not have an outpatient license to be able to become peer organizations. So currently in our regulatory model, to have peers, you have to have an outpatient license. But we have many community organizations that don't have that. We've been partnering with an organization now to provide that support, that they have the peer, but we offer the license. But that has to change, and I think that's when we're going to break into the communities that we haven't been successful breaking into, who have great caution towards mental health, but we have these limitations and guardrails. So I think looking at the regulations and the payment structure.
Thank you very much. Let's go to Chair Frankel.
Thank you and good morning. Thanks for being here. One of the workforce issues I've become familiar with, both my wife and my daughter are clinical social workers, is access to psychiatrists and prescriptive authority, that it's virtually impossible for many people to get psychotropic drugs that are necessary for them to be able to function. So I'm wondering, are you seeing that kind of constriction with respect to the access, from an ability to get appointments with psychiatrists to be able to get prescriptions?
Yes. I mean, that's sort of age-old. There's been a psychiatrist shortage in the state for I don't know how many years. I mean, and the most recent statistic is that 62% of citizens in the country don't have access to needed psychiatrists. There's a shortage. And the southwestern Pennsylvania in particular was identified as like a high extreme need for children's psychiatrists 10, 15 years ago, and it hasn't improved. One of the things that we supported as NAMI was for nurse practitioners to have full authority to write prescriptions. They didn't necessarily have to be working directly under a psychiatrist, because that's, in rural parts of the state that it's impossible for folks, not impossible, but long term. I mean, if the average wait for an intake is 3 months, say, the average wait to see a psychiatrist could be 6 months, 8 months. And a lot of times when you have that intake, one of the primary things that you need is medication, and you can see a therapist, you can have your intake, you can be evaluated, you can begin outpatient services, but until you see that psychiatrist, you can't receive prescriptions.
Yeah.
Thank you, Chair.
So I just want to note that, and from a standpoint of being able to address that issue shortage, we've introduced some legislation to expand authority for psychologists to have prescriptive authority with appropriate certification. And I would hope that
We
that would be
support
something that
as
you would
well.
support.
Absolutely. Our vice president, our board vice president, state board vice president is a licensed psychologist, and she actually started classes to be able to prescribe, so.
Thank you. We're going to do one quick question, and then we've got to get to the other part of the Behavioral Health Commission report, but we have to go to Dr. Venkat. Doctor.
Yeah, Arvind is fine. So I'm new to the legislature, and one of the concerns that I've had with initiatives in this workforce area, in healthcare in general, but particularly in behavioral health, has been the issue of what has been the successful track record in other states to actually bring people into and retain people in this workforce. Because we throw out the idea of tax rebates or credits, loan forgiveness, incentives to work in rural Pennsylvania, but I haven't necessarily seen a great track record of any of these being successful. There's a lot of personal factors that go into where someone decides to live, work, obviously go into the workforce. So my question to you is, what has worked in other states so that we can emulate that legislatively?
While you think about that, Representative Schlossberg.
I have, and thank you for letting me. So,
Representative Schlossberg.
what Dan said. That's a great question, Arvind, and I think we often get very, very narrow-minded when it comes to policy solutions. One of the things that I have struggled with the most in my time in the legislature, and specifically in my time in mental health, is we look at mental health as if it is a silo, as if you put in A, you will be able to address B and get outcome C. When the truth is, it's really not that simple. The example that I always use when we have this conversation is a study that came out a couple of years ago, which showed that every dollar that you raise in the minimum wage can reduce suicide rates by 1.5%. Because economics, quality of life, and social connections are deeply related to mental health. So to answer your questions, I do think that the things that we do in terms of tax incentives and recruitment efforts, they absolutely make a difference around the edges. But the simple answer is that if you're going to recruit a doctor, a nurse, or any medical practitioner to a community, that community has to be great. It has to have the things that are going to attract those people, which is why we can't just look at doctor recruitment and medical recruitment efforts within the silo of economics and healthcare. We have to take a broader community approach to it.
Stop making sense, Mike. And Dr. Frederick, we got to move in a moment. Do you have another response for Arvind?
I do just want to say that when we look at the information from National Council, for example, we're looking across the country, and the issues of why people are leaving the field are the same. The burdens and the strategies have been widely shared, so it's not just unique to Pennsylvania.
Thank you very much, both Dr. Frederick and Christine Michaels. Thank you so much. We're going to ask for our next two speakers to come on up. Thank you. Thank you. I'm going to introduce as we talk. Okay, I think, right? All right, here we go. So first, we're going to hear from Chief Jason Haberman. Chief is the Chief of Police in Mount Lebanon, where he supervises a staff of 112 and manages a budget of $11.1 million. He's developing a co-response pilot program to address community mental health issues and wants to implement and follow up coordination of care program. He also has a strong focus on mental health wellness issues for police officers. Thank you, Jason, for being here. With Jason is Dr. Lucas Malczak.
Yes.
Woohoo. He's the Director of Psychology of the Psychology Office with the Pennsylvania Department of Corrections. In his role, Lucas and his team are responsible for oversight for mental health care system, which supports PA's 24 correctional institutions and more than 39,000 incarcerated individuals. These two gentlemen are going to be speaking in relation to more recommendations from the Behavioral Health Commission. So thank you both for being here. Doctor.
Yeah. Okay. Get this here. Good morning, everybody. I'd like to start off with first saying thank you very much for having us here. Thank you for having the criminal justice system represented at this table, and thank you for having the Department of Corrections' voice heard in this important topic. On behalf of Dr. Laurel Harry and her entire executive leadership team, really thank you for including this. I think it's important before I get to my brief comments about recommendation 2 with Chief Haberman, it's important to understand the scope of the Pennsylvania Department of Corrections, our mission, who we are, and the kind of people who are delivering these mental health care services within the state prison system in Pennsylvania. Currently, we incarcerate approximately 37,000 people. Of those 37,000 people, approximately 40% are receiving mental health services at this time. If you remember back to Dr. Adair's conversation and his statistics, that's twice as high as what is observed in Pennsylvania and in the United States. So the prevalence of mental illness within the state prison system is enormous. If you break that number down even further and you look at the differentiation between men and women, a little less than 40% of all males in our system are receiving mental health services, and almost 7 out of every 10 females in our system are actively receiving mental health care services. Who's delivering these services for us? We have a broad, multidisciplinary, holistic treatment team present at every single one of our 24 state correctional institutions, made up of psychology staff, psychiatrists, nurses, corrections counselors, social workers, everybody wrapped around this person's mental health care. The 2 main priority disciplines who are delivering mental health care in our system are our psychology staff and our psychiatrists. The psychology staff include psychological services associates, psychological services specialists, licensed psychologists, forensic psychological services associates. For psychiatry, we have an external community vendor who is providing our psychiatric services. We have 48 full-time equivalent psychiatric providers. In our system on the psychology end, we have 275 frontline master's level clinicians who are delivering this direct patient care, both individually and in group settings. If we break the numbers down even further with the prevalence of mental illness in our system, back to Dr. Adair's number, if you remember, he said roughly about 4% of the community is diagnosed with some type of serious mental illness. In our system, it's closer to 8%. 8% overall. With the men, it's a little less than 8%. In our system, with the females, it's almost double. We're pushing 14% of our entire population of females are living with some type of serious mental illness. For us, that is schizophrenia, schizoaffective disorder, schizophreniform disorder, bipolar disorder, brief psychotic disorder, delusional disorder, major depression, psychosis, NOS, and substance-induced psychosis, in addition to other neurodevelopmental disorders like intellectual disabilities and autism spectrum disorders. In the fall of '22, I was asked by the Department of Corrections and the Bureau of Health, the Behavioral Health Commission, to provide some comments and ideas and thoughts about how to spend this money that has been allocated to Pennsylvania. I provided 3 primary recommendations, and I know I wasn't the only one who provided those recommendations, but those recommendations found their way into the final report authored by the Behavioral Health Commission. And so again, we say thank you from the criminal justice system in recognizing that we continue to be an enormous partner in ensuring the access to care, access to mental health care for Pennsylvanians who are incarcerated. We also continue to play an important role, an extremely important role, in ensuring access to mental health care for people who are leaving our system and coming back out into the community and living in our neighborhoods in the Commonwealth. The 3 recommendations that we had proposed included focusing on the recruitment and retainment of highly credentialed clinical professionals like licensed psychologists. We also emphasized the ongoing deployment and expansion of evidence-based practices in our system, and we also emphasized the expansion and ongoing deployment of highly effective continuity of care services. And so I'll briefly talk about those and then turn it over to Chief Haberman. My comments will be focused on the latter 2 recommendations of evidence-based practices and continuity of care. To be clear, within the Department of Corrections, we already deploy a breadth of evidence-based practices that basically fall into 4 buckets: screening, assessment, treatment, and training. And so Without going into detail, we have these evidence-based practices already in place. At the front door, when people are coming into our system, we're screening for intellectual disabilities with reliable and valid tools. We are conducting suicide risk assessments on day one that are complete with safety plans, which is a known evidence-based practice. Our assessments we are utilizing reliable and valid tools known to be accepted in the field. We are administering personality assessment inventories and other objective measures of personality so that we can understand how these people view the world when they come to our system. And it begins to help us prepare for reentering those people who will come back to the community for reentry purposes. We also engage in evidence-based treatment practices with cognitive behavioral therapies, psychopharmacology from our psychiatric providers. And our training, we believe, is we are employing evidence-based trainings as well to include mental health first aid. We have a very robust CITT program that has been in existence for the past decade or so. We've trained over 2,000 Department of Corrections employees to help with de-escalating people who are living with mental illnesses and experiencing a mental health crisis during their incarceration. We also have a very robust certified peer specialist program where we've trained close to 2,000 incarcerated people during the past decade, and we currently employ approximately 500 of those people in our system. Believe it or not, that certified peer specialist program is a reentry service for us. We are training these people with community vendors within our system during their incarceration so that when they do go home, those who are going to go home, they can seek employment as a certified peer specialist in the Pennsylvania community. The second topic that we had shared with the Bureau of Health Commission, Behavioral Health Commission, was we want to continue to expand our continuity of care services, both at the front door when people come into our custody from county jails, and also on the back door for reentry when we're sending people home back out into the community. It's so very important, and you can hear within my comments, and I think in everybody else's comments here so far this morning, that access to care is so very important. And so it's important when people come into our custody that we have the lines of communication that are opened with county jails so that they are providing us with as much information as they possibly can about these patients so that our clinicians are prepared to treat these folks and to prepare them for reentry. On the back end, it's the same issue. The Department of Corrections has a responsibility with ensuring that when we are sending those folks back home into the community, that we are doing so in a very adequate way and sharing the information on this person's progress in mental health treatment during their incarceration. So access to care begins on day one, and it doesn't stop until that person goes home. I was asked to provide some brief thoughts about how this money could help. I think if we continued to expand our evidence-based treatments and our evidence-based screening, assessment, training, and treatments in our system, we can continue to ensure the adequate access to mental health care for those people in our system, and hopefully continue to contribute to driving down recidivism numbers in the community. I think there are kind of easy early ways that we would be able to measure our effectiveness with utilizing these funds and others as well. We can measure those number of our staff who are trained in these new evidence-based treatments like dialectical behavior therapy. While that's not new, it's not as widespread in our system amongst our clinicians as we'd like it to be. We're more CBT focused, and we'd like to be able to expand into that space as well. We can measure the number of patients who are engaging in our treatments and accepting those treatments. So we offer treatment all the time, but our patients, just like yours in the community, aren't always willing to accept that treatment either. I'll finish with this. Our acting secretary, Dr. Laurel Harry, she was a warden at SCI Camp Hill, which is a main reception center. And one thing that she has told me throughout my career, and we've been friends for quite some time, has been that reentry begins on day one. And it's not surprising to hear that from somebody who works at our reception center. And so that is so very important as we prepare to return these people who are coming home into the community. Thank you for having me today.
Thank you. Chief Haberman.
Thank you. Thank you, Doctor. So, again, I'd like to echo the sentiments and appreciate the panels inviting me to speak on this very important issue. The issue of mental health, both inside law enforcement and for services within the community that we serve is something that is very important to me. This subject has, in fact, as we all know and outlined by the Behavioral Health Commission's report, has become front and center, and I'm very glad that it has. We are looking for sustainable funding models in order to really help law enforcement today, and we are asking for that help, and we appreciate those efforts to provide that. So first, what I would like to talk about is some initiatives that we're doing within the police department and how we are helping our officers in order for them to provide the best service they can to our residents and the residents of the Commonwealth. In addition to CIT training, crisis intervention training, and other programs that we are emphasizing wellness within our police department in order to help lower the temperature in the room of the police department that it currently exists. And what I mean by that is this. We're allowing officers those outlets, whether it's from a wellness perspective, whether it's a spiritual wellness, whether it's financial wellness, and whether it's any kind of component within their personal lives in order for them to be better positioned to serve residents. Again, as we enter into these programs internally, then we can best serve those externally. So what we've also identified is programs that we can speak to with respect to specific populations within our community. For example, those afflicted with neurodivergent disorders, we have done things such as develop Keep Calm kits, where we have kits where officers have the ability to have styming tools and other type of disability type measures that individuals use to cope whenever they're nearing crisis in order to prevent that from continuing. We've also done things such as partnering with driving schools in order to focus really on those with neurodivergent disorders in order to really emphasize how you react to law enforcement appropriately and how law enforcement can better serve them. In addition, we've done a lot of things with respect to partnering with other agencies such as ABLE, which is Active Bystandership for Law Enforcement. A real key component with ABLE and Active Bystandership for Law Enforcement is that we're focusing on the officers' ability to hand things off when they feel as though they've reached a certain point and they cannot continue dealing with a certain situation. So what we really focused on is the ability for our officers to then deliver the best services to the community. With that, I'd like to highlight an incident as we talk about coordination of care and the real things that I've become passionate about in order to help our officers serve those in the community. So this incident happened on July 29th of 2021. If I could just highlight the good work that these officers did for a moment, I think it's important. So if you would entertain this, it'll take a moment, but I think it's a very important example of care coordination and the effort that we're trying to solve. So on July 29, 2021, Mount Lebanon Police were dispatched to a possible homicide on Gilkison Road. The caller told the dispatcher that he had shot his parents and he wished to turn himself into the police. Being familiar with the caller and the address, mutual aid assistance was immediately notified and requested. Along with the MLPD officers on shift, additional officers from Dormont and Castle Shannon responded to the incident. Under the leadership of Lieutenant Patrick O'Brien, a plan was devised to set up a perimeter and safely take the male into custody. A team of officers, including Ryan Miller, Elizabeth Lewis from the Mount Lebanon Police Department, and Rob Barnes from the Dormont Police Department, along with George Daly, deployed a perimeter several houses away. At that point, simultaneously, two Mount Lebanon officers, Officer Elk and Bradburn, set up behind the residence in order to secure that location and garner his surrender. Once officers were in position, Officer Dave Lane and Dan Janeda from Castle Shannon Police Department, using their negotiator background, during that conversation with the actor, attempted to render a peaceful surrender. Eventually, when the male exited the residence, he exited with a rifle and began directing approximately 7 rounds towards the officers in the frontal location. At that point, as officers took cover, Officer Barnes was identified immediately as having been struck by a round from the rifle in his lower torso. Officers then evaluated Officer Barnes' injuries and secured him at that location. At that point, the actor then made his way to the rear of the residence and engaged in a running gun battle with Officer Elk and Officer Bradburn. During this exchange of gunfire, as he advanced towards Officer Elk and Bradburn, and they became pinned down in the bushes. At this point, they were in the rear of the residence. While attempting to seek better cover, Officer Bradburn sustained a lower body injury. Recognizing that Bradburn was in immediate danger, Officer Elk essentially rescued Bradburn from that position and assisted him to a location where he could be evacuated and treated. As the actor continued shooting, the involved officer maintained tactical positions while attempting to care for their injured counterparts. At some point during this chaos, the actor escaped in his vehicle and a pursuit ensued. When it ended a short time later, the actor rolled his vehicle in Upper St. Clair, pursuing officers' approach, and eventually found the actor deceased from a self-inflicted gunshot wound. In summary, while the incident began as what we believed as a peaceful surrender, all officers involved quickly found themselves in the middle of an extremely violent and dangerous situation. They all performed professionally and heroically, and their actions prevented further injury to the public and residents and their peers. All involved officers are an asset to the law enforcement profession and the community, and they are to be commended for their efforts. Now with that, the reason I bring this incident up, what's really important to note that's not noted in this incident, is the individual involved. We had 4 dealings with this individual 4 weeks prior to this incident. This individual was known to the Mount Lebanon Police Department to the point that we had an intelligence book devised and available should this individual enter into crisis and attempt to do something. The really sad situation involves this individual's parents obviously lost their lives, and a number of other community members were affected, a number of officers were affected, and we had no means to have care coordination prior to this incident. So what I back up and say is on July 12th, this individual exhibited signs of crisis, schizophrenia, other behaviors that really were consistent with mental health disorders. As we went through this process of dealing with this individual, we utilized things such as 302s, involuntary commitments, voluntary commitments. We utilized the health system. We attempted to use every resource available to us, and there was no resource available to maintain care coordination with this individual in order to get that individual the help that he needed in order to prevent a crisis like this from occurring. This is a story we hear time and time again in law enforcement. It's a profile that fits a number of different examples that you can cite in recent memory, locally and nationally. And what we're asking for from a police perspective is that we have that coordination of care and we embed that individual in an appropriate place. What we've identified is EMS, police, and fire are the 3 silos of response. While we don't want to create another silo of response, we believe right now if we embed that care coordinator with EMS, that care coordinator can overcome already existing hurdles in things such as CREA, Criminal History Retention Information Act, and HIPAA, which prevent the sharing of certain health-related information. And with that, if we embed this care coordinator, what we're really asking for is a sustainable model of funding in order to allow our officers to have that continued follow-up and that resource allocation. What's really critical for us in law enforcement is we recognize we're not the best to handle every situation that comes across our radio or that comes across 911. But what we're asking for is that coordination of care, and we want to really focus on identifying individuals that we can build this program with. And we appreciate the partnership we have, whether it's with Department of Corrections, Allegheny County resources locally, and other state resources. But this next level of real co-responder model, we believe, rests in that care coordination piece that has been missing for so long.
Thank you, Chief, and thank you, Doctor. And obviously, very impactful. Appreciate it, and you know I know the story well. So, but thank you for sharing it.
Sure.
Appreciate it. All right, my friends, we have some good questions here. We're going to have to go a little bit quick here to stay somewhat close, but we're going to start off with Representative Mays.
Thank you, Whit Miller. My question is for the doctor. For me, my work has been around women's health in all capacities, particularly women of color. So my question to you, you talked about the number of female inmates who are dealing with some type of mental health diagnosis. So my question to you is, when they're coming into a system of incarceration, either at the state or county level, they may also be coming with an experience with sexual or domestic violence, and a lot of them are mothers as well. So they're arriving to any of our correctional facilities. What's your opinion? Do you think that exacerbates their mental health condition? They may be showing up with it, but how does their experience with incarceration, make it, either maintain it or make it worse? Especially when we talk about isolation and segregation and other, other ways that incarcerated women are experiencing their time.
I appreciate the question, and I think you're spot on with the concern. I think the two kind of schools of thought pertaining to risk for that population, and as it pertains to a secure setting like ours, is importation, so they bring risk with them, and then the other type of risk it's called deprivation. So what does the secure setting, how does that make it worse, potentially and unintentionally? And I'm not certain what the exact answer is. I can tell you that on day one, when women come into our system, as well as males, because we know that the population who comes into our custody are far more likely to experience trauma, especially the women, but the men as well. We are screening for that on day one with an empirically validated tool, the PTSD Checklist 5. So it's a very widely accepted tool, and based off of the results of that screening, we are routing these patients to be enrolled in a group that's called Seeking Safety. This group is built to help people deal with trauma. It's delivered both individually and in a group setting, and so we are rather well aware of this concern and the issue, and we're doing our darndest to meet that need in that population so as to prepare these people, for those who are going home, to go home safely.
Thank you for that. I want us to work together around a set of bills called the Dignity Act bills that address trauma-informed care for mothers in particular who are incarcerated. So if you haven't seen it or looked at it yet, we passed it out of Judiciary Committee. And I think this is a huge opportunity for us to address mental health for mothers who are incarcerated and women who are incarcerated in general. So thank you, Doctor.
Thank you.
Thank you.
Thank you. Thank you, Rep. And that is a great legislative effort. We're going to try and do a couple real quick, and I'm going to go to Leader Costa and then to Rep. Benham. No, you're right? All right. Rep. Benham. Thank you, Leader.
Getting stuck here.
I should have
There
given
we go.
heads up on the mask. You got
No, it's all good. I
Time.
figure disability space, so I'm trying my best to keep folks safe. So my question really is for the Department of Corrections. I had the opportunity to visit the NRTU at SCI Albion, and that was a incredibly eye-opening experience. I had visited other units before, and it's a really stark difference. And I'm wondering if you can speak a little bit. There's a big overlap comorbidity between folks who are neurodiverse and folks who have mental health issues. And I'm wondering if you can speak to what specialty units are contributing and how the department may be considering expanding those.
Sure. Thank you for the question. The unit that the representative is referring to is our neurodevelopmental residential treatment unit. It is located at SCI Albion, so up in the northwest by Lake Erie. That unit has been in operation for several years, and it really came on the heels of self-reflection of the department, led by former Secretary John Wetzel and now Dr. Laurel Harry. We identified this gap, right? And that gap was, we make decisions by data. And we looked at our 40,000 people that were incarcerated in and around that time, 2 to 3 years ago. And we had 13 people diagnosed with an autism spectrum disorder, which is something like 20 to 40 times lower than you would expect in the community. And so we weren't doing a good job of those practices that I referred to earlier, the screening, the assessment, the treatment, and the training of our staff in identifying these people. And so access to care was somewhat of a concern at that point in time for that population. Since then, we have developed this unit. We have enhanced those 4 buckets for this neurodevelopmental population who we are seeing. And so we started at 13 people, and we are now approaching 50. That might sound like a small number, but it's actually a massive number on this really small scale. We have expanded our training for our staff up at SCI Albion, and our hope is that the successes and the kind of lessons learned up at SCI Albion are going to allow us to replicate that unit when it's clinically appropriate to do so. As our numbers continue to grow, the need will continue to grow, and it won't be able to be absorbed by just one facility based on what the data tell us. We certainly, there are other specialized units that you inquired about, and the range of needs that we deal with and that we are expected to treat while these people are in our custody is it's unbelievable. The qualified mental health professionals in the Department of Corrections, including our nursing staff, our medical staff, and our psychology staff, and really the entire team, it's unbelievable. We have very dangerous people with us who also bring with them and develop serious mental illnesses while they're with us. Back to Dr. Adair's numbers, our rates of serious mental illness are twice as high as what they are in the community, and our rates of suicide are close to twice as high as what the community experiences. And so the expansion of those evidence-based practices, we think that we could help drive those numbers down to a level that we'd be more comfortable with as well.
Absolutely. Thank you for that answer, and looking forward to continuing to collaborate and support however I can.
Thank you, Rep. And Representative McCurry. Go ahead.
Thank you, Dan, for sneaking me in, and hello. Pleased to be here. Thank you for your testimony, guys, and the work you do. My question is really for Chief about a delivery of services on the beat, so to speak. In Hampton Township, and I'm sure you've seen this example in different places, but Chief Valakovich has pioneered a method where he partners social workers with officers on certain calls, and he's gotten a really, really good response. They're able to treat and help in a different way and sometimes de-escalate. You gave some examples of similar things like that. I was curious if you've thought of that or seen it elsewhere in the community, and if not, we'd love to partner with you and share what we know. Thanks.
No, I appreciate that. Yes, I am familiar with that. We've looked at that model as well. One of the things that we found in specific to our county, with the 109 police departments I mentioned, everything may not work for everybody is what we're finding for a number of reasons, whether that's the resources that a department may have or may not have, or the geographic location or the population size and demographics. And so what we've looked at is we have looked at the social worker model. We've looked at a model where we have an internally trained detective that we have coordinate the program with social workers. That is something that is, again, an option as we move forward. And we're looking at what is best for us and for our area. Again, we also have to look at the call volume and really the scope of work that individual may or may not be able to do. And what we found is if we partner, again, using our local EMS agency, they service 5 communities locally that are similar in demographics and similar in size in the sense that population size. And so what we can do is we can scale that locally for us. However, that is something that we constantly evaluate, and we really, what I found, and actually I've spoken to Chief in terms of the program and others, and I can tell you that what we found is the more you do it, the more work that they have. And so that is the telling part of this program, is there's such a need. So absolutely, I'd love to pursue that, and we're looking at, again, at what fits us best.
Thank you, Rep. 2 quick things. One is I want to thank Representative Salisbury, Abigail Salisbury, for joining us. And I got to go finally to the social worker, Rep. Abney.
All
All right, I'll be brief. Thank you, Whip Miller. My question is for Dr. Malashek as well. You mentioned the comprehensive wraparound mental health services that are provided within the system, which is a very controlled environment. You also alluded to preparing folks for their transition back into society, and you also kind of alluded to the fact that once that happens, it's kind of out of your control at that point. And so we know that once that happens, folks have limited access to maybe the medication that they had when they were inside the system, as well as may take 8 months to see a psychiatrist, right? So do you have any data or information around the recidivism rate for folks who specifically get mental health treatment within your system? Is it higher than the general population, or what does that look like?
Thank you for the question. I think our Bureau of Planning, Research, and Statistics just published a 10-year recidivism report within this year in 2023. I'm going to take a stab at recalling the data, but our numbers were not too different. So those patients who are actively receiving mental health care, it was in the 60% range of recidivism, I believe, over a certain period of time, which is about what it was for the rest of our population. Just to provide some more clarity behind this, you asked about service preparation for continuity of care when people are going home. For patients that are actively receiving psychotropic medications, unless it's clinically indicated to not provide those medications. So if we believe that they can't be safe with them for a period of time upon release, which I think is quite rare, we are providing a 60-day supply of medications. And we have set intervals that our social workers and our psychology staff are beginning to make community contacts to ensure that patient mental health appointments with psychiatrists and psychologists and social workers in the community, we are setting those appointments up at 18 months out, 1 year out, and then 6 months out, and then as needed before that person eventually goes home. And so I appreciate your comments and your question.
Thank you, thank you. And I want to thank everyone here. Thank you, gentlemen, for all the information. Chief Sharon, the personal thank you for the men and women who did such a strong job on that night as well. Thank you for sharing that. Thank you both. We do have to switch to our final section on mental health, which is a panel on mental health in schools. So we're going to ask our panelists to come up. Let's see here, one moment. And again, this is our final discussion on mental health for this morning. We will then switch to our disability topic this afternoon. But this morning here, thank you. Okay, we have our two first speakers that we have here. One is Amelia Pfeiffer. She has been a high school counselor at East Allegheny High School for the past 28 years and was recognized as PA Schools Counselor of the Year in 2019. She's currently also serves as the executive director of the Pennsylvania School Counselors Association, where she oversees operations of this over 1,000 member organization. Thank you for being here. And as well, we also have Emily Bourne. She's a school-based liaison supervisor at the Allegheny Office of Behavioral Health in the county. She has extensive background in social services, working with youth and families, and is passionate about working with multidisciplinary teams to bring about systemic change. Thank you.
Thank you for inviting me here today and for acknowledging the importance of school counselors in addressing student mental health within schools. The first thing I'd like to refer you to is within your packets you were given this school counseling as primary care. We view ourselves as the first point to address student mental health within schools. However, most of the funding that has been allocated to address student mental health lately has gone toward school social workers as well as school psychologists, which is a good thing. I do not want to disparage school psychologists or school social workers in any way. However, we as school counselors address the needs of all students. If you wouldn't mind turning, within your packet, and you will see this later, within here there is something that we call the MTSS triangle. It's the multi-tiered systems of supports. And it kind of shows you how all of us within the mental health profession fit in to address student mental health needs. So school counselors, along with school nurses, we're sort of at the bottom where we have to service all of our students, regardless of whether they are presenting with a mental health crisis or whatever the situation is. So we have to, go into classrooms. We do universal screeners. We address mental health crises as they come up. However, we also then provide referrals to more specialized support, going up to the Tier 2 levels, which may be small groups, things like that, and Tier 3, which is the more individualized, more specialized interventions for students in need. And that's where we see our school psychologists and our school social workers. They are fitting into those Tier 2 and Tier 3 more specialized needs, which is great. But again, like I said, we also need to address all of those other students within our schools to see if there are any, needs that may not be evident initially. And we are the ones that are there to address those. However, what we're asking for is, some reasonable ratios. We are stretched way too thin, as has been the whole theme of this morning. Everyone is stretched way too thin. But I just want to give you some statistics on that. Our students, on top of all of their mental health needs, they're also suffering significant learning losses of half a year or greater due to the pandemic. And if you look in the beginning of the packet that I mentioned, the Pennsylvania Youth Survey that was given in 2021, we call that the PAYS survey, that indicated that 1 out of 5 students reported that they have seriously considered suicide within the past year. 1 out of 5. So that was self-reported by students. So we as school counselors, we're getting ever-increasing caseloads, and we often work in isolation. The average counselor-to-student ratio in Pennsylvania is 1 counselor per 343 students. Myself at East Allegheny High School, I have over 300 students, well above the 1 to 250 ratio recommended by the American School Counseling Association. Further, half of Pennsylvania public school districts have a ratio of 1 to 350 or higher, and 1 in every 10 school districts has a ratio over 1 to 500 students. To make matters worse, there are fewer school counselors in our schools than there were in 2010, even though class sizes have increased. Another thing that is in your packet is our school counselor staffing report, which shows that the inequality from district to district is also staggering. It hits our most vulnerable students hardest. Of the 192 school buildings where students do not have access to a school counselor, roughly 80% of these are elementary schools and 76% are Title I schools. Almost half of Pennsylvania school districts employ school counselors who are assigned to multiple buildings, making it impossible for students to meet with counselors when they are not present in the building. So it's up to you guys, our legislators and elected officials, to support school counselors across Pennsylvania and establish reasonable funding and counselor-student ratios to reverse the trend of declining student health. How can we do that? An investment of $130 million, less than 1% of the total state appropriations for education, would be enough to hire the total school counseling positions needed in Pennsylvania. by increasing the state's investment by less than $100 per child. We can bring counselor-to-student ratios down to an average of 1 to 250 and ensure students have access to a qualified school counselor without compromising the counselor's ability to do their job. Additionally, we as school counselors need a clearly defined scope of practice. And I often say, what I'm doing in my building at East Allegheny High School might look very different than what's going on down the road at Woodland Hills or Penn Hills or any other school district. It might even look different between my building and my elementary building. We don't have a defined scope of practice. And because of that, we are used for many different things that might or might not be within our scope. For example, the ASCA national model provides a clear definition of scope for counselors, recommending that 80% of counselors' time is spent in direct service of students and 20% spent on program planning. So without clear guidelines, we're being used for non-counseling duties such as covering classes, monitoring hallways, and administering standardized testing, all which limit students' ability to access the mental health support that school counselors provide. Within your packet, there's also a handout from the American School Counselors Association that defines the role of school counselors and what we, as trained professionals, master's level school counselors, should be doing. I also want to direct your attention, this is something that I always talk about. There's a handout created by the Pennsylvania School Counselors Association that compares the old guidance counselor to school counselors. If there's one thing that you remember today, I want you to remember that we are school counselors. The term guidance counselor is outdated, and it no longer defines what we are able to do within schools. Finally, within the school staffing report, you're also going to notice that Pennsylvania is the only state in America that does not require school districts to outline comprehensive programs, nor does it require a specific ratio of student to school counselors in school buildings. In fact, we don't mandate school counselors at all within our schools. So I'd like to reference the School Counseling Services Act. It is House Bill 662 that Representative Dan Miller as well as Representative Mandy Steele have introduced. It fills the gap by requiring schools to develop a robust school counseling plan with goals of improving access to quality mental health support via counselors, meeting the highly individualized needs of students and easing student transition to post-graduation life. This is a bill that costs zero money. It would be something that we could implement within all schools fairly readily. And as Executive Director of the Pennsylvania School Counselors Association, I'm prepared to offer training and the model that is recommended by the American School Counseling Association to all schools within Pennsylvania. One other thing, I also want to thank Representative Schlossberg, who attended our Mental Health Youth Summit that we, as PSCA, put on back in December at our pre-conference. So thank you for attending.
Thank you, Ms. Pfeiffer, and just for members, of course, any of the information is on that, available on that QR
Yes.
Code. So thank you, and let's go to Ms. Bourne.
Good morning, everyone. Thank you so much for having me. I'm here to talk a little bit about some of the higher tier supports that were referenced earlier. So specifically, I wanted to discuss the Student Assistance Program. The Student Assistance Program is something that is mandated in all of Pennsylvania secondary schools, so middle and high schools. This is a requirement that all school districts have a program put in place to support their students that are struggling with barriers to learning related to drug and alcohol or mental health needs specifically. This program was initially put in place in the late 80s, early 90s, specifically in secondary schools after seeing an increase in drug and alcohol concerns as well as suicides. This program specifically identifies individuals within the school setting to bring these students to the attention of their core team to identify what the needs are, and then hopefully put them in connection with a screening that can help get them connected to further supports. The individuals that do those screenings are supplied by county supports. So in Allegheny County, we currently have providers that are connected with all of our public school districts that are providing this student assistance program liaison support. They are put in place to conduct screenings of students that have been identified as high need, that need to be connected to further mental health supports or further drug and alcohol supports. They're also in place to try and provide group programming to students in these school districts to try and help with a prevention sort of model, to do drug and alcohol groups, grief and loss groups, social skills support groups, whatever might be needed to really be specialized specific for that school and those students in need. What we've been finding is that although this program was put in place, like I said earlier, for those secondary schools, there's a significant need for the elementary schools. Our providers in Allegheny County have looked at the need, have had discussions with their school districts, and many of them have expanded their services to provide supports in the elementary schools. This has been within the continued funding model that hasn't had a significant increase for close to 30 years. What we've seen is that our students in the elementary level, specific in Allegheny County, about 40% of the screenings that our student assistance program providers have been doing are at the elementary level. And this is something that's really been stretching our providers based on how that funding is set up. They're working to try and provide that support in the secondary schools, but because of this ask for the elementary program, some of them have been stretched very thin. They've been unable to provide the groups that they've been hoping to do. They've been unable to do some of the additional education that they've been hoping to do because they've expanded to that elementary level. And what we've seen is with that, within the past several years, many of our providers have had to make the difficult decision to pull out of providing this service because they haven't found it to be sustainable within their organizations. And then that's leading to our youth having a hard time accessing services. For the staff that we have in place, our student assistance program providers that are working with schools, their job becomes to help link these students, these high-need students, to mental health supports. And what we're finding increasingly is that those mental health supports don't exist in the same way that they have previously due to the staffing needs that almost everyone has addressed already today. What we're finding is that our student assistance program providers, who are meant to really be a linkage, are acting as a bridge to care. They're in place with these kids, providing one-on-one connections and support until they're able to start services, sometimes 3 months later, sometimes longer. We have multiple mental health providers that are available in most of our school districts in Allegheny County, and I know across Pennsylvania, many school districts have partnerships with other outpatient mental health providers. However, this is something that we're still seeing as lacking because our students aren't able to access those services due to staffing needs. They're full, they have wait lists, or like someone mentioned earlier, they're no longer even taking wait lists, so they don't have to say they have a wait list. So what we're seeing is that all of our providers are stretched thin, and within the school system, that often then falls on our counselors, who, as we already heard, are already 1 to 300 students, and our kids continue to be in need, and that need continues to increase, and we see that then in our crisis response. So we're looking at what that program is and what our staff need to improve services, and it's looking like our providers are asking for additional support in that area.
Okay, while I look for questions, I was just talking with Representative Innamorato. Your program, Emily, is that in every county? Is every county doing it?
Yes.
Okay, all right.
That's across Pennsylvania.
That's a good service. Questions? Rep. Innamorato.
And Emily, can you clarify, is your program funded through the state entirely, or is it a match that's put up by the county?
It is funded through the state and the county. The counties have put in significantly more funds than the states have at this time.
And how much additional funding would you need to be able to get the providers necessary and the workforce that you need in order to provide adequate service, well, let's say quality service, to all school districts in the county?
Our providers are giving us different answers for that. Right now, we're actually going through a shift because additionally, one of our providers have pulled out. So I don't have a specific number at this time, but that's something that we could get back to you with.
Thank you.
Thank you. Okay, thank you both for your testimony today. We do appreciate it. Our final two speakers I'll ask to join us here. While I introduce them, first is Dr. Stropke, who I'm very excited to see. He's been the, the superintendent of Keystone Oaks School District for the past 11 years. Over the past 35 years in education, he's worked in several local districts in a variety of positions, including assistant superintendent, middle school assistant principal, elementary principal, federal programs coordinator, and physics and math teacher. He's also served as an adjunct professor at Point Park University. He's been a great ally to my office over the many years of our work together since Keystone Oaks is part of my 42nd district. So good to see the doctor here. And Shannon Fagan, hello, thank you, Shannon. She's coming from the Allegheny Intermediate Unit, as always, where she's currently working as a project coordinator for supporting expansion and enhancement of K through 12 school-based emotional supports. That's SEEKS. What do you call it?
SEEKS SES.
SEEKS SES. Okay. All right. That's a long one. No, I don't know. Anybody else find that long? All right. Project coordinator for supporting expansion and enhancement of K through 12 school-based social. Some things don't need acronyms.
Right.
Maybe you just, I don't know. Okay.
I did not pick that.
You didn't pick it. All right. This is a unique partnership between the Allegheny Intermediate Unit and the Allegheny County Health Department that focuses on directing targeted assistance to 10 high-need local school districts. So thank you for being here, and we will start with Shannon. Thank you, Shannon.
Okay. Good morning, everyone. Thank you for having me. I'm very excited to be here. And Dr. Adair, hello. I used to work with Dr. Adair at the state, and I appreciate all the work that you guys put into looking at children's mental health. As the former mental health director, I felt the need to just continue to build that circle of support around our kids, around our communities, but our provider networks as well. And with Project SEEKS, it is a 2-year, very short drop in the bucket grant that the health department received and wanted to focus on those 10 school districts, looking at the behavioral health needs that they have, but also other metrics such as poverty, COVID, vaccines, and so on. So I can't even go into all the metrics. But regardless, those 10 districts have participated in asset mapping with us and have really given us an idea of I don't want to say what's lacking, because they all have wonderful strengths and they all have wonderful, caring people in their buildings. They just don't have enough. They don't have enough support for social, emotional, anything. And our kids are just really suffering. And you'll have to forgive me because this is a very passionate conversation. My son suffered mental health, and some of his family or best friends, actually, one of his best friends last night committed suicide. So it's a little tough to sit here and think about this on Children's National Mental Health Awareness Day. You know, we have a need to provide supports, and our schools are where our kids are. Our schools are where our families connect. And if we can't engage our families and can't engage our school partners, how are our kids going to be successful? And part of SEEKS is also working with 3 universities. We are working with Duquesne, Chatham, and the University of Pittsburgh to try to bolster that pipeline that everybody has talked about, that pipeline into mental health, into education, and making sure that our future educators and mental health clinicians, school counselors, school psychologists have what they need to deal with today's kids, to deal with that trauma that they're going through, the things that we're seeing. And so I'm here just to think about those things with you and figure out how do we support and build our communities. And Chris, and I'm sorry, I forgot your name, what you guys were talking about with the families. Our families lose their jobs when their kids bounce out of these programs. And suspension and expulsion is so high because they don't know what to do with them. So it's easier to send them home than it is to try to figure out, because they just don't have the support. It's not that they don't care, it's just what do we do? And I can tell you, I've seen some really wonderful people that I partner with in this room, and our services can be there, but we don't have the funding to grow those services. And we don't have the future staff. People are not interested in these careers anymore, and it's not just because it's financial. They need more training and support to be able to deal with what they have to deal with in those buildings and in the communities. So thank you.
Thank you very much. Bill?
Thank you, Dan, and it's a privilege to be here and sit in front of the legislators here. First of all, while I'm here as the superintendent of the Keystone Oaks School District, I'm also representing, I think, all of the superintendents across the Commonwealth. but also looking at not just the 501 public districts, but let's also talk about our private and parochial as well too, because we're all facing the same thing, and I'm fully aware of that. I guess you could probably say my story and the Keystone Oaks story is a tad bit different, and that's why Dan and his staff had us here, because back in 2016, we realized in our community that there was beginning a change, and everybody that has testified today has told you that story. Out there, we saw a number of agencies shutting down. We saw the quality of their work going down. We saw various agencies in that folding. But we had a response in Keystone Oaks to meet the needs of all the kids. And so we started without funding, and make that clear, without the funding, not coming to you or the legislators or anybody and saying, hey, we need this, we need that. And I know that I always have had the ear of whoever the Secretary of Education was. I know I have more of the ear now because we have two high officials in the Department of Education who are from southwestern Pennsylvania. I guess part of that's too is because I'm the old superintendent now in the county, and maybe across the state. But I want to say a few of these things. We have 1,886 students in our district. I have one high school counselor for every 200 students. My story is different, but it's not everybody's story across this Commonwealth. It's not everybody's story. In my middle school, I have two counselors for 380 kids, so divide that in two. In the elementaries, I have one counselor in one elementary for 235, my smallest elementary. And my other two elementaries, 330 and 300 and 325. There's a counselor in each. We recognized that we had to do it because we had to meet the needs of the kids. And so we did it. In addition, in 2017, and no, this is all prior to that thing called COVID, that day, which was March 13th, 2020, when we all sat in front of our tea, and some of you were in your positions at the time, when we listened at that time, Pedro Rivera give his speech about education. That's a different story, Dan. You'll have to have a different panel for that. That's a different story. But what we had to do in Keystone Oaks, we realized that because agencies, both county and state, were not supplying, or were the staff, the workforce was starting to dwindle then. We had to take it upon ourselves, and at that time, we hired two of our own mental health therapists. Was not an easy thing to do, because it wasn't a business that we were in, and we had to learn. And it was tough, and we're still learning. In addition to all those counselors I just mentioned, we have three mental health therapists in our school district full-time employed by us for 1,886 students. We have a school psychologist. From the support of my board, we will have two psychologists in the fall. We've added staff because we've had to, because the mental health issue is prevalent out there. But that's the Keystone Oaks story. That may not be the story at where any of you are representatives. I know two of you sitting here today, actually, well, there were three at one time, are representative of some parts of my district. For those of you who are out east, my district, if you look at all the school districts, is that only school district that has 3 dots on the map, because I have 3 communities that do not touch each other. They are not, I am not a continuous flow. I have to go from one to the other. We have to pass through the city of Pittsburgh, or the good chief is gone. My office sits in Mount Lebanon, and I don't pay them any taxes. Isn't that great? We pay them nothing. Sorry, Dan, no, we're not. We're not going to get started. But we're very unique. But we had to take a role, both the administration and the school board. We had to take a role that was a different shift, because we know we can't continuously run up there and say to Harrisburg, we need more money, we need more money, we need more money, because we know what it is. We had to figure it out, and we had to struggle in other areas to make this happen. It's not easy, but we have to meet the needs. And I can go on and on with those pieces, but all of my pristine colleagues today, both in this part of the program and before, they've said the story. This is the Keystone Oaks story, but you have different stories out east and in the central, and even here in Allegheny County, there are different stories. But here's one thing I'm going to say to you. I am fully aware right now that sitting in both chambers in Harrisburg are two bills. You got two bills that are talking about free lunch, okay, for everybody. There are so many families in southwestern Pennsylvania, in my district, that are struggling right now because of the conditions of the economy. That free lunch will alleviate pressures in the household, would start off the mental health issues that we now have to deal with. That if you can get that through, I applaud both houses. And I know there's two versions of the bill, they're out there. That would be phenomenal if you could, because what we're looking at is how do we alleviate the pressures in the household so they're not making their way into our schools. We're also starting to look at how we can do parent programming to help the parents work through. I'm redesigning my entire administrative staff right now and their roles. I guess you can say I am a different superintendent. I started in this business in 1988. This is 2023, but life has changed. Education has changed. And we sort of heard it today. If something was not working in March of 2020 in our business, or in the mental health business, it sure is not working in 2023. And we like to say in schools, public schools weren't working across the country prior to it. We weren't with the times. And why I bring that up to you is that we also need to, I need the legislators, I need you to think about this. And I'd be more than happy, obviously at the permission of my board, to come and travel and so forth and talk with you more. We really need to take a look at the Pennsylvania School Code from, let's stress it, 1949. That is strapping us. And even though we have all those omnibus bills that are passed and you get those little changes, it's not enough. That 990 or 900-hour concept is outdated. That puts pressure on students because they don't learn that way. There are certain things in there that have to be alleviated. What I'm trying to say to you is I'm aware that there are things that we can do in schools to alleviate the pressure. What I do hope is that there's funding. This is going to seem odd, that there is funding that you can give to higher ed to better train so that I can find people to put into our buildings for next year. We have a crisis. And if we don't have the properly certified people for counseling, as we heard from my colleagues, counselors, school psychologists, mental health therapists, social workers, we're going to be in trouble. You know, we hear that there's a teacher crisis. I get it. But there's that crisis too. We'll find it. We'll make it do. So I appreciate everything that you are doing in Harrisburg for us. I would say that we would love to. I'm only one of 43 superintendents in Allegheny County. I know for some of you that's amazing because out east you don't see that, but we have 43 public districts in Allegheny County. We would love to bring a contingent out to you and just talk about what I said about school code and so on and so forth. That would start to help from a different angle the mental health crisis and stuff and how we can better meet the needs of the kids. So Dan, thank you for having me.
Thank you, Dr. Stropke. As you can tell, he had nothing to say, so it's really good.
You didn't tell me anything.
Let's go to Rep. Innamorato.
Thank you, folks. So Rep. Hohenstein and I, we are co-chairs of the Welcoming PA Caucus in Harrisburg, which focuses on immigrant and refugee justice. And so I'm wondering, we've seen in Allegheny County a rise in the Latino and AAPI communities, which brings with it students who need ESL programs. So I'm wondering how you're ensuring access to mental health services, not only through language access, but also resources that are culturally competent.
Yeah, so from my district perspective, I have a pretty decent size of ESL students for a district that is my size. But I do have to say that in the one particular population they're performing pretty well. Because it's not all about academic growth, it's not all about academics, but it's about growth, achievement, social and emotional, and their well-being. So we address all of those without calling it social and emotional, because I never want to be attacked in my district that we're promoting this concept called CRT. We don't. We do what education has always done. It's what you do right for kids. We address that. We have a high need. We have a high percentage of students in our district from Nepal. That's different it's a different country and a different culture compared to what a lot of see. And we spend a lot of time with those students making them understand, first of all, what it is to be a student in America, how to work with each other, and meeting their culture. And that takes time to give professional development to the staff to understand the changes that you're seeing and how to meet their needs. Because we've talked about today, you heard counselors, you heard mental health therapists, you heard psychologists, but the regular classroom teachers need the help too. It's everybody that needs the help to be able to address that. I believe in spending if I'm going to spend my money, I'm going to spend my money on good quality, high quality, continuous professional development. I'm going to do less, but more with it and go more in depth to meet the needs of those students who are coming through. So that ESL population, I can speak to, we are addressing them and addressing their needs. And every one of them is a little different. Nobody has the same story.
I can just, the 10 districts that I'm working with are also dealing with that. And because we're having that university connection, they would like more support from the universities around reading and that's just one thing. But I do know that the schools themselves, the counselors are spending an awful lot of time connecting those families with services that are appropriate for them and then engaging them into what services are here and how we can be helpful. So that building that cultural diversity among our services as well and understanding how different cultures receive services is really important. And that needs to be education as well.
And there's also one thing that I forgot, and that was this. Even 8 years ago, I recognized that there was going to start to be a need. And so what I did was unlike any other district in the county did. Most of us have just had a director of special educational services and they oversaw everything. I split that job. I needed a director of pupil services and I needed a director of special education because they are different. And I realized for the future, and I am so happy to do that because I have a director who is focused on the needs of the kids with the counselors and trying to do outreach in the community, which we're looking to do more next year. There's a lot of things we couldn't do because during COVID, it wasn't the right time because we didn't see students this and that, but we're trying to play catch up now to meet those needs. So we've also added administrative staff to be able to do that.
Thank you both. Rep. McCurry.
Thank you both for being here and for your testimony. My question is in regards to the dynamic that you're talking about, Dr. Stropka, with the rethinking and innovating education beyond its 1949 roots. And that really stood out to me. In this moment that we're at as legislators and those who are thinking about education policy with the mental health of our students in mind, and we've heard some really startling statistics today about 1 in 5 considering suicide and mental health pervasive in our young people. How open would you be, or should we be, to a change in format in our schools away from this traditional rows and columns, block by block in terms of grade-wise, step-wise, to individualization, and school counselors as a guide, if we can get enough of them in the schools, and catering things so that students really are getting what they need and they feel heard and are in an environment where they can navigate an academic path, that they move up when they're ready and they get the services they need when they're ready. If you could just speak to that a little bit from your perspective.
Sure. The easy way to respond to that is, Dan, if you give me everybody's email addresses here, I will send you our strategic plan, because in our strategic plan that was to go into effect on July 1st, 2020, so we know where that fell, which we couldn't do. We had already been planning 3 years ahead because we know our philosophy at Keystone Oaks is education, number one, needs to make sure that no student is marginalized. None. That's by looking at the curriculum and the services. They need to be there. Marginalization means let's make sure that we're hitting the needs of every child. Two, we have to focus on the whole child. It's more than just a PSSA score or a Keystone score that you hear all the time. It's about growth. I'm no longer, if my scores come out great when they publish them, wonderful. But I know my students are growing because I have mechanisms that I could prove to people internally that they are growing and moving. It's a growth model, okay? Number three, we're making sure that we are future focused. And to your point, we've already started, we have committed hundreds of thousands of dollars over the next 3 years to remodel every one of our classrooms. We have a model classroom right now in one of our elementaries that the teachers will be looking at next week. New furniture, new dynamics, but what's importantly is teaching the teachers a new instructional model in delivery. And how do you deliver to the new modern student? No, how do you deliver in 2023? Because the rows don't work. They don't work. The engagement doesn't work. And when students are engaged, that's when your behavior goes up. Your issues go up. It has to be for them. And my point about the school code is that there are straps in the school code. We should be allowed. Well, who says that you have to be in school for the hours that you say, whatever? What about, we've learned through COVID that we could do a little bit of that online. It's not for everybody, but there can be an anybody. Why not allow different, students that want to start early, high school, 8 to 3 or whatever, that's great. What about not starting until 10 for some of them and blending in? There's a lot of work we have to do with what I call the various unions and so on and so forth to adjust that. I understand that. But getting all of the P organizations, I call them, in the state together, I think that's a great start to get everyone together. But we are already looking at to do it, but it comes down to professional development with our staff to teach them how to do differently. I mean, I tease about this all the time. I will begin July 1st, 36 years in education July 1st. If this old man can figure it out, because I've talked with people clear across the country, because my board has allowed me to travel, not only locally. And what I'm speaking to right now, I want to stress to all my colleagues, there are 35 other school districts in southwestern Pennsylvania that are looking to do exactly what I'm doing. We are part of the American Association of School Administrators, which is the Superintendent's Association. Southwestern Pennsylvania is recognized across the country for the work we're doing to try to innovate and change how schools are. So it's not just me. We would love to bring a contingent to all of you, and some of you represent, some of your superintendents are part of that. And we would love to work with you to how we can change that. But that will affect the mental health.
Thank you. Our final question will go to Rep. Deasy. Chair.
Thank you very much. It's more of a comment, and I had an opportunity to sit down with the superintendent a few weeks ago, and he's done a great job in the ability to change and listen and grow in your role. And we had talked about a few weeks back your board allowing you the opportunity to go learn best practice throughout the country. And I think you're a great spokesman for how things have changed in the education field. My father was a principal many decades ago. And in those days, a lot of times the school day ended at 3 o'clock. And right now it doesn't. And unfortunately, some of the situations that students are subjected to in their own community and the violence out there that they're facing, again, you mentioned also the food issue. We need to be cognizant of that, and we need to let the money flow to the districts to allow you to grow. Go find out what's working throughout the country. And again, I just want to commend you for being willing to learn and grow and letting our students succeed. As you said, it's not a one-size-fits-all. Scores are great to promote certain PSSA scores, but at the end of the day, every kid's different, and I appreciate the work that you do in our community.
And thanks, Dan. I do want to say this. Make sure that those monies also flow to these outside agencies and so on and so forth, because when they do leave our doors and don't come back for another 12 hours, It's what's happening in the community. You heard from the police chief. You heard some other things. They really need the support and the help out there and that partnership that we have. But thank you, Dan.
Thank you. First, I want to thank all of our panelists, for this whole discussion on mental health this morning, but obviously finishing up with Shannon Fagan and Dr. Stropke. Thank you very much. Everyone, this will conclude our morning session on mental health. This afternoon, we will be coming back at 1 o'clock with Dr. Arkush, the Secretary of Human Services. So we hope that many of you will be joining us for that key discussion. And then a panel, again, with some of the legislators, not all, but they all have busy things to do, but some legislators will be a part of the 2 o'clock panel as well. So before we close, I want to be sure to thank a couple of things here. First, I want to thank, again, we did the speakers, but I want to thank every one of my colleagues who've made an effort to come. Some of them come from very far away to be here. And so I hope you'll join in me in giving them a round of applause for coming. Yeah, I gotta point out too. And look, there was a couple different events, so I'm sort of tongue-in-cheek in this, but I got to give a special shout-out to Representative McCurry. Look, the only Republican who came. But thank you, Rob. And I'm joking a little bit. Some of our friends who are usually here, Senator Bartolotta and so forth, they had some conflicts. But thank you, my friend, for making this bipartisan. As always, Rob's been here ever since he's been elected. So listen. We have, if you haven't heard, our resource fair is going full throttle. It started from 11, will go to 1 o'clock. So that is in motion. We hope you have a chance to take a look at it. As we close the morning session, I want to be sure to also thank our sponsors today. If you haven't had a chance, St. Clair Health, unique source, fantastic organization. We very much appreciate them helping us keep this thing all free and open for everybody that's here. Thank you very much. We'll see you at 1 o'clock. Please join the resource fair.